Mamounas is giving us the third presentation. These are results from the NSABP B-42 trial, randomized double-blind placebo-controlled clinical trial to evaluate extended adjuvant endocrine therapy, 5 years of letrozole, in postmenopausal women with hormone-receptor positive breast cancer who have completed previous adjuvant endocrine therapy. I think what you probably have noticed in the past year, there's one or two big stories in breast cancer. The first one was the MA17R trial looking at extended adjuvant endocrine therapy. And so the results from B-42 are extremely important for our patients who are struggling and our physicians who are struggling on what to do and whether to recommend extended endocrine therapy. Dr.
Thank you, Virginia, and I'd like to thank the program committee for the opportunity to present these results of the press program, and also for selecting them for presentation in the main meeting. It's my privilege on behalf of our co-investigators at the NRG Oncology and NSABP to discuss with you the results of the NSABP B-42 trial, which was a randomized, double-blinded, placebo-controlled clinical trial of extended adjuvant endocrine therapy with letrozole in postmenopausal women with hormone-receptor positive breast cancer that have completed prior adjuvant therapy with an aromatase inhibitor. So we know that extended adjuvant endocrine therapy after 5 years of tamoxifen with either tamoxifen or an aromatase inhibitor improves disease-free survival in early-stage breast cancer. We don't know, of course, which is the optimal duration of adjuvant aromatase inhibitor beyond 5 years of therapy. The NSABP B-42 aimed to determine whether 5 years of letrozole versus placebo improves disease-free survival in patients who have completed 5 years of hormonal therapy with either an aromatase inhibitor or with tamoxifen followed by an aromatase inhibitor. This is a schema of the trial. Postmenopausal patients with invasive breast cancer, estrogen or progesterone receptor positive, stage 1 to 3A diagnosis, and who were disease-free after 5 years of endocrine therapy consisting of either an aromatase inhibitor for 5 years or up to 3 years of tamoxifen with an aromatase inhibitor to complete the 5 years. Patients were then stratified and randomized to 5 years of letrozole versus 5 years of placebo. The primary endpoint of the study was disease-free survival, and this was defined as local, regional, or distant recurrence, cancer in the opposite breast, second non-breast primary cancers, and deaths from any cause as first event. Secondary endpoints included overall survival, breast cancer-free interval that was defined as a recurrence of breast cancer or appearance of breast cancer in the opposite breast as a first event, distant recurrence, osteoporotic fractures, and arterial thrombotic events, essentially ischemia, infarction, cerebrovascular events, and peripheral arterial thrombotic events. From September 2006 to January 2010, we accrued 3,966 patients. 43 patients were excluded because of 36 having no follow-up and 7 not being at risk of the primary endpoint. The median follow-up for the remaining 3,923 patients included in the efficacy analysis was 6.9 years, and the required 631 disease-free survival events for definitive analysis occurred by August of 2016. There were no significant differences in patient characteristics between in patient tumor and prior treatment characteristics between the two treatment groups. About a third, 34 to 35% of the patients were under 60 years of age, 57 to 58% were node negative, 39% received prior tamoxifen, and 61% of the patients had breast-conserving surgery. The median duration of treatment was 59.8 months in both groups, and overall 62.5% of placebo patients and 60.3% of letrozole patients completed 5 years of therapy. The main reasons for letrozole treatment discontinuation included patient withdrawal or refusal in 13.8%, adverse events in 9.6%, and disease progression in 4.1%. On to the results. The primary endpoint was disease-free survival, as mentioned. There was a 15% reduction in disease-free survival event, as we see here with a p-value of 0.048. Now, you may think that this is statistically significant. However, the level of statistical significance in the study was set at 0.0418 because of adjusting for the interim analysis, the pre-planned interim analysis. There was some alpha spending. So technically, this is not statistically significant difference. At 7 years, the disease-free survival was 84.7% for letrozole versus 81.3% for placebo. When we look at the contribution of different first events in the disease-free survival endpoint, the major difference came from a reduction, reduction in distant recurrence with 87 events in placebo and 61 events on letrozole, and also a reduction in opposite breast cancer, 59 events in the placebo and 30 events in letrozole. There were no significant differences in any of the other endpoints, that events that went into the disease-free survival endpoint. When we look at the cumulative incidence of breast cancer-free interval event, we see a 29% statistically significant reduction in favor of letrozole. As we can see, at 7 years, the cumulative incidence of breast cancer-free interval was 10% for placebo and was reduced to 6.7% with letrozole. When we look at the cumulative incidence of distant recurrence, there was a statistically significant 28% reduction in distant recurrence. At 7 years, cumulative incidence of distant recurrence was 5.8% with placebo and 3.9% with letrozole. There was no significant difference in overall survival. We see that the hazard ratio was 1.15. There were 164 deaths in letrozole and 146 deaths in placebo. The 7-year overall survival rates were 92.3% with placebo and 91.8% with letrozole. When we looked at the cumulative incidence of osteoporotic fractures, there was no significant difference. As we see here, at 7 years, 5.4% of the letrozole patients and 4.8% of placebo patients developed an osteoporotic fracture. And lastly, when we look at the cumulative incidence of arterial thrombotic events, again, there is no statistically significant difference between placebo and letrozole. The hazard ratio is 1.21, and numerically, as you can see, there are more arterial thrombotic events with letrozole than with placebo. An interesting observation here was that in the first 2.5 years, letrozole actually had the beneficial effects on arterial thrombotic events, and then there was an increase in arterial thrombotic events after 2.5 years. And there was a significance in the non-proportionality of the hazard rates. So in summary, what we found was that the beneficial effect of extended letrozole therapy in disease-free survival did not reach statistical significance, but there was a 15% reduction. There was no significant difference in overall survival. Extended letrozole provided a statistically significant 29% reduction in breast cancer-free interval event, and also a statistically significant 28% reduction in distant recurrence. Letrozole did not significantly increase risk of osteoporotic fractures or arterial thrombotic events. However, risk of arterial thrombotic events was elevated with letrozole after 2.5 years. So in conclusion, and to put the results in clinical perspective, our findings suggest that careful assessment of potential risks and benefits is required before recommending extended letrozole therapy in patients with early-stage breast cancer, including patient and tumor characteristics such as age of the patient, nodal status, existing comorbidities, information on bone mineral density, and also the tolerance of the aromatase inhibitor in the initial 5 years. We hope that genomic classifiers that predict risk of late recurrence and/or benefit from extended endocrine therapy may help to further individualize the recommendation for extended aromatase inhibitor therapy, and such studies are actually being planned currently in the B-42 cohort. I'd like to acknowledge the patients that participated in the study, the NSABP investigators, coordinators, Hannah Bandos and Barry Lembersky, part of the protocol team that did a lot of work in preparing for this presentation, the NSABP Operations and Biostatistical Center staff, and also the NCI and Novartis who supported the trial. And I'll be happy to answer your questions.
First question, so these results seem similar as far as the magnitude of benefit to MA17R, but those results were statistically significant. Your primary endpoint is not. Right. What are your thoughts of comparison, cross-trial comparison? So
at first glance, our results look discordant between MA17R. However, actually, when you look at the endpoints, the results are fairly similar. MA17 reported a 34% reduction in disease-free survival event. Their definition of disease-free survival was essentially the same as our definition of breast cancer-free interval, was breast cancer recurrence and opposite breast cancer. And we saw a 29% statistically significant reduction in breast cancer-free interval. From last time point, we were very similar. When they included deaths from any cause in the disease-free survival endpoint, and that's in the paper, there was only a 20% reduction in the incidence of disease-free survival event, which was not statistically significant at the p-value of 0.06. And our difference was 15%, also borderline statistically significant. So the results are very similar, but you have to choose, if they chose a different definition of disease-free survival. The more common definition includes our definition, which includes second primary malignancies other than breast cancer and deaths as a first event, because those relate to the comorbidities of the patient, and you want to see the effect overall in the patient population that you study.
So basically, if you have a healthy patient without many comorbidities, both trials are pointing toward at least discussing and strongly considering.
Particularly a younger patient, a patient without comorbidities, and particularly patients that have significant risk for breast cancer recurrence, node positive disease, multiple positive nodes. Those are the patients that clearly will benefit from the treatment.
Lynn Peterson with Trends in Medicine. So I want to follow up on that last answer. So basically, you're suggesting, even though the data suggests that there wasn't a overall survival benefit, and you missed the primary endpoint, that there are patients for whom this extended therapy would be beneficial. Can you identify those patients more clearly for me?
Yeah, I mean, it's essentially what we just discussed. Those are preferentially will be healthier patients with not significant comorbidities, younger patients with a long life expectancy, because also the endpoint of contralateral breast cancer or opposite breast cancer, you get much more benefit if you have many more years to live. And also patients that have high risk for recurrence, such as, for example, patients with positive nodes, large tumor size, high-grade tumors, or even prior genomic classifiers that classify patients at high risk that may have been assessed at the baseline when the patient was diagnosed.
You haven't studied those patients. Do you have a subset of
that? No.
Is there an analysis with a subset of those patients?
Subset analysis are sometimes are exploratory, obviously, because as I will show in the presentation, there was no interaction in the benefits of letrozole in different subsets, so the benefit is there across different subsets. However, again, you have to balance the pros and cons when you make that recommendation, because apparently, as we will see here, there is some increase in arterial thrombotic events, and there's some other events that potentially offset some of the benefit. But yeah, those analyses will be obviously done and presented in the publication.
And I'd like to point to the morning session today, where there will be 2 other papers discussing, not as extended, but still extended endocrine therapy. One of them will have a very detailed subset analysis. And I think putting all of those together, and Dr. Ganant is going to talk about it and summarize all these papers, including MA17R. I think that will give you a good idea of the patient population that will benefit from extended use of endocrine therapy.
Marisa Weiss, breastcancer.org. You know, the whole conversation about extended adjuvant is the opportunity to make an impact is of question when you think about how many people actually make it to the 5 years on their initial leg of their anti-estrogen therapy, and then how many of those people have now been shifted from their oncologic follow-up care team to their primary care team, and how many doctors can really engage people at the 5-year mark? How many people are left at that 5-year mark to even have a conversation about extended adjuvant? And then how can those primary care doctors really have the correct conversation about the opportunity to extend it to 10 years? When, for example, let's say you have a postmenopausal woman who's status post mastectomies, for whom half the benefit of extended adjuvant, because you're not reducing the risk of contralateral, presumably. How many of those, how can that conversation really have traction, and how can we make sure that the studies you're doing, the important studies you're doing on extended adjuvant, really have the impact that they could have?
Right. I mean, I think that's an important point, and this conversation is probably better to take place with a medical oncologist or a surgeon that follows the patient long term, because unless primary physicians are aware with all these results, it will be a difficult conversation to have. But clearly, you require a lot of knowledge. But you're absolutely making a very good point that patients, for example, that have bilateral mastectomy do not benefit from a reduction in contralateral breast cancer. There was still significant reduction in distant recurrence, as we showed. However, again, the benefit is less when it comes to the disease-free survival endpoint. And again, as it was pointed out before, there's no survival benefit with neither of the trials presented so far with the addition of extended adjuvant therapy. In fact, in our study, the hazard ratio is a little bit towards the placebo, not the letrozole.
Hi, Caroline Asco Post. 2 questions. One, to echo what she was saying about compliance. You had a good compliance rate, 60%.
If I can answer that question. Yeah, but 60% of the patients, I think the question you asked, and I forgot to answer, how many patients get it to the 5 years? At least when it comes to treatment in our study, about 60% of the patients completed 5 years of therapy. So the majority do, but certainly there are patients who do not reach the 5-year mark, for sure.
Yeah, I think in the community, it's not 60% probably. So did you make special effort to keep patients on therapy?
Obviously, we did. I mean, patients had to report taking the medication and send forms in. The investigators sent forms in. So we definitely encourage compliance with the medication. But yet, we did see that about only 60% of the patients completed 5 years of therapy. Now, other patients completed some therapy. It wasn't all 60% or nothing. Okay. But certainly, compliance is a major issue. But the majority of those patients, as you see, they stopped medication because of their own preference or potential for.
One more quick question. Do you need longer follow-up? Because ER positive recurs later. And is 6-something years enough? Or do you think if you followed out to 10 years, you'd see a statistical difference?
Right. It's possible that we may see a statistical difference. Clearly, more follow-up is needed because, as you pointed out, estrogen receptor-positive breast cancer disease that potentially can recur 10, 15, 20 years later, and hopefully we'll have the funding to continue the trial. Also, we'd like to see if any of the trends in terms of the potential for arterial thrombotic events or other comorbidities will actually increase over time. So definitely we'll follow these patients for several more years.
This will have to be the last question. Just remember that speakers will be available after the press conference. Thanks.
Terry, wonderful work. So in MA17R, there was an excess of non-osteoporotic fractures in the letrozole-treated patients. Did you look at that?
No, we did not have any excess. Well, actually, our secondary endpoint was osteoporotic fractures. There was not a lot of difference in other fractures as well. But
do you know if anyone was giving some special bone-directed therapy to these patients?
Yeah,
because at least in Austria, Prolia prevents the fractures.
So we looked at because one of the questions that came up was because there was a little bit more of a trend in patients that had low BMD score. Was it an effect of bisphosphonate? And the answer is it doesn't seem to be. There are patients, about 36% of the patients were taking bisphosphonates when they entered the trial. When we asked these patients if they plan to continue, 99% of them said they were continuing. And when we asked the patients that were not getting bisphosphonates if they were planning to start, 99% said they weren't planning to start. So, but the effect of bisphosphonates did not figure into the results. However, I think there was another part of your question that maybe I did not answer. Yeah, but there was no difference with bisphosphonate use in terms of the endpoints.
And my recollection is that in MA17R as well, the 2 arms were balanced as to the use of bisphosphonates.
Right, and same in our trial, because it was a baseline assessment.
Okay. It wasn't very, very high.
No, it was not.